The recording as a with the recording.
Good morning and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is a digital partner of this event organized by Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anesthesiologist, Forum of Cardiac Anesthesia, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Healthcare Foundation. Now, allow me a moment to inaugurate the session with a short video.
Good morning and welcome to the Sunday PE and Critical Care Echocardiography breakfast session. I'm really privileged and proud to welcome you. And as already announced, this is being conducted under the auspices of Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anesthesiology, Forum of Cardiac Anesthesiology, Bangalore, Global Intensive Care Symposium, International Society for Cardiac Ultrasound, and the Global Heart Care Foundation. And I'm really happy that Dr. Sanjeevani Namdar and Dr. Amarja will be with us today to deal with the subject of diastology, which is a very complex subject in this arena of echocardiography, but it has a very important clinical applications. And before I request Dr. Sanjeevani to take over, I would like to request all the audio participants to put their questions and comments in the chat box, and we will try to address all of them at the end of the session. And with that, I would like to request Dr. Sanjeevani Namdar, who is the senior consultant anesthesiologist with a lot of experience with echocardiography, both transthoracic as well as transesophageal, and who is special to me in the sense that she can correlate the clinical findings with the echocardiography findings and give a appropriate impression of the clinical condition. So that is the advantage of having the knowledge about thoracic as well as cardiology. So with that introduction, I would like to request Dr. Sanjeevani Namdar to take over and conduct the meeting. Thank you so much. I'll be with you all through the session till 10 o'clock.
Thank you, Dr. Murlidhar. Good morning, everyone. And this is the beautiful continuous medical education which Dr. Murlidhar is doing for so many years. consistently and helping all of us manage our patients in a better way, day in and day out. And I'm privileged today to introduce none other than my friend, my Maharashtrian friend, Dr. Amarja. She is a dynamic cardiac anesthesiologist from DM from Jaideva. And now she is in Aurangabad, joined the which group, Amarja? Ozone group. Ozone group. And really, she is well versed with the topic, managing patients, very dynamic, very bubbly. And we are eager to listen to you, Amarja. Go ahead.
Thank you, ma'am. Thank you so much for that kind words. And let us just start with the today's topic, because it is a very, very important topic. And thanks to Dr. Murlidhar Kanchi sir for giving me this opportunity. And thank you, Inamdar madam, she is today here to guide us more on this topic. And you all may think that this is such a complex topic. The waveforms are so complex, and we have to judge all these and know all these complex waveforms, and then we have to manage the diastolic dysfunction in the patients. But let me just try to simplify it as much as possible today. And yeah, let's proceed. Evaluation of LV diastolic function. As we all know, left ventricular systolic dysfunction is well recognized and ably managed by anesthesiologists. Left ventricular diastolic function needs to be reckoned as well every single time anesthesia is planned in a patient with cardiac disease. Diastolic dysfunction is the insufficiency of the LV to allow filling at the lower atrial pressures. In other words, it is the abnormal relaxation during diastole along with the reduction in LV compliance, which culminates into higher filling pressures of the LV. If the ventricle is stiff and non-compliant, it is unable to fill properly at the low pressure fillings, low pressure filling state. In order to allow proper amount of filling during diastole, the pressure has to rise. This is the basic physiology that gets altered in diastolic dysfunction. As we all know the etiology, I will not go into details. The primary myocardial diseases such as any cardiomyopathies can lead to diastolic dysfunction. Secondary hypertrophies due to aortic stenosis can also cause diastolic dysfunction. Ischemia, infarction, extrinsic constraint can also lead to diastolic dysfunction. So as we know, the main problem is the impaired LV relaxation and increased LV stiffness, which can lead to two conditions, as they are nowadays said, that heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So we all know that in systolic heart failure, it is mainly the cardiac output is decreased because the ejection fraction is decreased, the contractility is decreased. But in case of diastolic heart failure, the preload is decreased. That is the main crux. Less blood enters the ventricle due to stiff and non-compliant ventricles. That is the basic difference, and we have to address both of them. The management of both of this is totally different. So let us now go to all the echocardiographic features wherein we can diagnose diastolic dysfunction. So this is a echocardiographic video of diastolic dysfunction where you can see a dilated heart. So in this case, this is a non-compliant stiff ventricle which doesn't contract properly. So there is a systolic dysfunction as well in this. There is global hypokinesia along with diastolic dysfunction in this patient. It is associated with comorbid conditions many a times, such as hypertension, diabetes, and atrial fibrillation. Oftentimes it is asymptomatic at rest, but it can manifest in the stress-induced conditions which do occur during anesthesia or in the perioperative period, such as acute severe hypertension, tachycardia, overzealous fluid administration, or any type of arrhythmias, particularly atrial fibrillation. Diastolic dysfunction can manifest. It's an independent predictor of MACE, major adverse cardiac events. So it has to be addressed immediately and thoroughly. It can contribute to postoperative heart failure. It cannot be ignored. Diastolic dysfunction cannot be ignored. Now, to understand diastolic dysfunction better, we have to know the phases of diastole. You all must be very well versed with the phases of diastole. It's very basic, but just me go through rapidly and tell you that what happens is when systole occurs, the LV is contracting and the blood is going out of the aorta or the aortic valve, right? And the aortic valve immediately shuts down. When the aortic valve shuts down and the mitral wall is yet to open, there occurs a phase known as isovolumic relaxation phase. In this, both the valves are closed. Then the mitral valve opens as there is initiation of the diastole. And when the mitral valve opens, there is rapid gush of blood from the LA to the LV due to the pressure gradient, right? So this rapid filling gives a wave, which is known as E wave, is the early filling phase or the early filling wave. You just see, name it as E. E is the early filling, right? So it is the E wave that occurs. Then occurs a period when during the last phase of this E wave, a small amount of blood comes down to the LV, which is the diastasis. In diastasis, very small amount of blood comes into the LV. And then what happens? Whatever the remaining blood is there, it comes to the LV through the atrial kick. We all know about the atrial contraction, last atrial contraction, or the atrial kick, what we call it as. This is the A wave. So what happens is, during diastole, the early filling phase occurs and then the atrial contraction occurs. So these two waves are there, which are called as the E wave and the A wave. Okay. So now most of the things are dependent on this E and A wave. That is why I've simplified it earlier in this session. And now we are going to grade it. This grading is done basically in the presence and absence of elevated LV filling pressures. So how do we grade it? Diastolic dysfunction grades are impaired relaxation patterns. First is normal. Okay, so there is normal relaxation. Grade 1 will be impaired relaxation. The relaxation is impaired. Grade 2 is pseudo-normal. It appears like normal, but is it normal? So we have to do some maneuvers and some things so that we differentiate if it is a normal or if it is an grade 2 or a pseudo-normal stage. Grade 3 is the restrictive pattern. In this restrictive, again, two types are there. One is reversible and one is irreversible. So majorly there are three types: the impaired relaxation, pseudo-normal, and restrictive. There are certain parameters on which we will diagnose the grades of diastolic dysfunction. It is mostly the transmitral flow velocity, that is the E and V wave, which I've just said. Then the mitral annular velocity, we are going to see in detail. The LA volume index and the tricuspid regurgitation velocity, I'm not going to go into such details of this two. Then pulmonary vein flow and propagation velocity, we are going to see in detail today. So this was all I was talking about. What we do is when we take the transmitral flow velocity, we take the PWD and we keep it in the mitral inflow, and then we do the pulse wave Doppler. Once the pulse wave Doppler is seen, we get certain things which are like, this is the E wave. See, a pulse wave Doppler is placed at the mitral leaflets, at the tip of the mitral leaflets, and you get this E wave and the A wave. This is the pattern, typical. This is the E wave, the diastasis, wherein very less blood flow occurs, and this is the A wave. This is called as the biphasic pattern. There is something known as triphasic pattern as well, which we will see in detail. This is the biphasic pattern, which is the E and A wave. E, as I told you, it is the early filling filling of the LV. So it is the early filling velocity. A is the atrial kick. You can just remember the atrial contraction, A wave. Then we can have a ratio of this two. We can see the A duration, that is time interval, that for how much time the blood is coming down during atrial contraction. We have the deceleration time. What is deceleration time? How rapidly the E wave comes to normal. That is the deceleration time. And isovolumic relaxation time, that is the time interval between aortic closure and the mitral opening. That is also taken into consideration. So this is the E and A wave form that we have told. What all does it tell us? The E wave velocity reflects the LA and LV pressure gradient during early diastole. It reflects LA pressure and the rate of LV relaxation. Changes in the E wave also indicate changes in the filling pressures. The A wave velocity is reflective of the LA and LV pressure gradient during late diastole. This is when the atrial kick occurs. Normal E wave is less than 1 meters per second, or just say to be particular 0.6 to 0.8 meters per second. The main factor that determines E wave velocity is the pressure gradient between the two chambers. So this is a transthoracic view, okay? And this is the E wave, the A wave, the deceleration time, the IVRT, and the A duration. These are all the parameters that are seen. Now coming to the deceleration time is mainly 140 to 200 seconds. Some take it as up to 240 milliseconds as well. Diastasis, as I told you, there is no significant flow that occurs. In A wave velocity, atrial kick, always remember 0.2 to 0.35 meters per second. In tachycardia or AF, the atrial kick is lost and therefore A wave might be absent. So this was all I was talking about. This is the normal or the pseudonormal pattern of the E and A wave. This is TEE image. E and the A wave pattern, and then this is the impaired relaxation pattern, wherein you can see the E is smaller than the A. So whatever blood now remains into the LA has to come out, come down to LV, and a big LA contraction occurs. That is the atrial kick occurs. A big LA contraction occurs, or the atrial kick, and then passes all the remaining blood. Therefore, this A is higher than the E. So here alters your EA ratio, right? So now this is impaired relaxation pattern. This is the normal pattern. Now, if you say that this can be normal or pseudo-normal pattern, so what you have to do is here you apply the Valsalva maneuver, and if the pressures come down or the waveform comes down back to normal, it is the normal pattern. Otherwise, it will be a pseudo-normal pattern. And this third is the restrictive pattern. In this restrictive pattern, you can see that the deceleration time is steeper. This waveform is steep. Yes. So there is a large gradient between the LA and LV, and immediately the gush of blood occurs into LV, and this E wave comes down to baseline immediately. This is called as the restrictive pattern. Here also either vasodilators are given or Valsalva is done to differentiate if it is a reversible or an irreversible restrictive pattern. So same things now I'm going to repeat. This was just the explanation of the diagram, and similarly we are going to repeat so that it gets fixed in our brains. Okay, so EA ratio is a key measure when we evaluate diastolic dysfunction. The ratio and pattern suggest if the diastolic filling is occurring at a proper time and rate during diastole. In the early stages of diastolic dysfunction, there will be a decrease in early rapid filling phase with an increase in atrial contraction. So there will be E pattern will be, E will be less and A will be taken more, and atrial contraction will be increased. That is what I just told. To compensate for the lack of filling of the first stage, to compensate for the E, A is bigger. Okay. This ratio provides both prognostic and diagnostic information. Now coming to E and A ratio, it is normally 1 or 1 to 2, you can say. It is load dependent. Diastolic dysfunction causes reduced EA ratio, as I just said. Impaired relaxation result in reduced passive filling, so smaller E wave and a larger A wave because of larger atrial kick. Same things are explained in this as well. E wave decreased due to impaired relaxation. E wave increased due to LA pressure increased. And this is the steeper, this is the restrictive pattern, wherein also E to A wave is larger than 1. So this table might be very scary, but trust me, it is not scary at all. What I just said is this is the normal pattern, and grade 1, grade 2, and grade 3 diastolic dysfunction. EA ratio increases. The DT is also something that decreases. DT, yes. Then we are going to see about the E and E prime. What is E prime? We are going to see. Just you have to remember the septal and the lateral E prime and its values, and we are good to go then. So this is the impaired filling pattern, which I have just explained. Pseudo-normal pattern, restrictive filling pattern. Okay. Now coming to a triphasic. I just said there is a triphasic wave as well. E and A wave pattern is the biphasic pattern, and there is something, a small wave which comes in between E and A wave is the L wave. L wave, when diastasis is a little longer, like if bradycardia occurs, or if there is too much of diastolic dysfunction, or LV compliance is very reduced, then this diastasis might take little longer. If this diastasis is longer, some gush of blood will appear in the LV from the LA, and between the E wave and A wave, an additional LV is seen during mid-diastole. This wave indicates continuous pulmonary vein flow from the LA into the LV even after E wave. Predisposing factors are reduced LV relaxation in conjunction with increased LV stiffness and elevated LA to LV pressure gradients. Prominent LV denotes diastolic dysfunction. Okay, so this is spot diagnosis. Now coming to very important, that is the pulmonary vein flow. I like to explain this in detail because when we see the pulmonary vein flow, no, we get confused and we are like, this is too complicated, but it is not. If you understand the physiology behind it, it is very, very interesting. And today, if you listen properly, you'll never forget it, because this is my favorite thing. Pulmonary vein flow, how do you take it? Usually you take it in the left atrial pulmonary vein, left upper pulmonary vein. And how do you get it? We get it in the two-chamber view. You have to just adjust for the pulmonary vein, and you have to place the PWD over there. And and you get something like S1, S2, and D. Now this is a trans that was trans. This is transesophageal. Yes. So this is SD and A waves we get. So this is where the sample volume is taken. Yes. And how do we get this SD and A? Now we are going to see this. S is actually, there are two components, S1 and S2. I'll explain in detail. See, what happens is S is systole. Okay, so what happens is systole is of LV. Always whenever we say systole, it has to be of the LV. Whenever systole of the LV is occurring, LA is relaxing. When LA is relaxing, blood is coming from the pulmonary vein into the LA. Because the direction is towards, from the pulmonary vein, blood is coming into the LA, direction is towards the transducer. So you get a upper waveform. Okay, upwards waveform you get. So this is first the S1, which occurs because of LA relaxation. Now what happens when LA is reducing, the base of the LV is going down. There is more space in the LA available, and more blood is coming from the pulmonary vein into the LA, which is causing S2 component. Fine. Two components, S1 and S2. S1 is occurring because of S systole. Systole is of LV. Systole. And now at that time, the diastole is occurring of LA. So more blood is coming from the pulmonary vein into LA. That is causing S1. Then the base of the LV is going down. So more space is created. More blood is coming from the pulmonary vein into LA. This is the S2 component. Now happens the diastole. Diastole is of the LV. When diastole is happening, mitral valve is opened and the blood from the pulmonary veins directly gushes to the LV. LA acts only as a conduit. So the blood is coming again from the pulmonary vein towards the transducer. You get a positive wave. Fine. And now A is, you can say, the atrial contraction, which occurs lastly, and therefore this is the negative wave when the blood goes into the LV. So that is the atrial contraction. Blood goes away and you get a negative wave. I hope you are clear and you'll never forget this explanation. Okay. So this is diastolic dysfunction, wherein the S wave is lesser and the diastole is the bigger. Okay. So this is the explanation for the pulmonary veins. Tissue Doppler imaging. Now coming to tissue Doppler imaging. What is tissue Doppler imaging? What happens when the blood is coming and these E and A waves are forming? At the same time, what is happening is LV base is also contracting, right? The LV apex is always fixed. It cannot move. It is fixed. What moves is the LV base. It moves on up and down. This movement is captured by the tissue Doppler imaging. We press the cursor on the lateral and the medial annulus, and we measure its velocity, how much it transcends or how much it moves during each contraction. So in that way, mitral annular velocity is measured, and in diastolic dysfunction, this medial velocity is lesser than 8. Normally, it is like medially it is 8, laterally the movement is slightly more, and it is more than 10 centimeters per second. These velocities you have to know. In medial, for medial annulus, it's less than 8. We say it is a diastolic dysfunction. For lateral, less than 10, we say it is a diastolic dysfunction. Fine. So this is more than 8. You can see here. Fine. Yes, medial and medial E wave velocity is more than 8. We say it as E wave. E prime, we call it as E prime and A prime. You can see our cursor is at the medial mitral wave annulus. E wave and A waves are seen. That is E prime and A prime. Sorry. Fine. So when it is less than 8 centimeters per second, it is suggestive of diastolic dysfunction with increased LV filling. You can say it is 6.53 over here. It is lesser, and this denotes diastolic dysfunction. So now a ratio of all the permutations and combinations are done, and a ratio of E by E prime ratio is also taken, and then we can diagnose that how much LV end diastolic pressure might be in this patient. The normal value is less than 15 of E by E prime. More than 15 suggests increased LV EDP. Flow propagation velocity. This is again one of the parameters from which we can diagnose diastolic dysfunction. Isovolumic relaxation, it creates a gradient between the LA base and the apex, and this causes a suction effect. Therefore, preferential flow, that gush of blood what I'm talking about, this preferential flow occurs during this E wave, that is the early fizzing wave, towards the LV apex. And what we do is we typically take it like from the first aliasing velocity of this mitral valve from the mitral valve annulus to 4 centimeters into the LV cavity. We take it and we call it as the flow propagation velocity. It is load independent. So it is important to know this. What are its values? Less than 55 centimeters per second in younger patients, and less than 45 centimeters per second in more than 30 years suggests diastolic dysfunction. So we have to have a steeper one or a vertical flow. When this gets slanted, more diastolic dysfunction ensues. That you should know. It should not be slanted. Fine. You might find this a very complex picture, but it is not. Go one by one, and you see the mitral inflow E by A wave. Normal, impaired, the atrial kick takes more, and whatever is remaining is blood is taken down by atrial kick, so A wave will be more. Then pseudo-normal, again it may mimic the pattern. You have to do Valsalva maneuver and see actually what it is. In the reversible, you will have a steeper E wave, yes, and less than 140 milliseconds. So this is very important. In this, again, vasodilator is given or Valsalva is done to differentiate between the two. The pulmonary veins SD and A, I think you must have understood in a better manner. Propagation velocity, I told you, the steeper it is, steeper it is better. As it is slanting, it's bad. Tissue Doppler imaging, again, I have explained everything in this. So that was mainly about the how you diagnosed and the evaluation. Now I do have a few slides of diastolic dysfunction. Let us go through this. So this is a case of diastolic dysfunction. You can know just by having the first look at the LV. Severe diastolic dysfunction. This is the pacemaker lead. This is the dilated cardiomyopathy. Then other is restrictive cardiomyopathy. I will not go into the theoretical part of it. So in this restrictive cardiomyopathy, you can see that there is no dilatation, but the LV is stiff, and that leads to this picture. This is restrictive cardiomyopathy, wherein biatrial dilatation is seen. Where this is pathognomonic, this is like the diagnosis of restrictive cardiomyopathy, biatrial enlargement. It's for diagnosis type of. HOCM, we all are very well versed with this. You can see the hypertrophied ventricle, the interventricular septum, and you can also mark the systolic anti-motion, that is the SAM over here. Fine. Yes. All these conditions cause a lot of diastolic dysfunction. Whenever you see this, you should always have in mind that this patient will have higher grades of diastolic dysfunction, and you have to start evaluating it from that point of view. Now, just to complete the my today's session, I will just give you the key points in anesthesia implications. The act of administration of anesthesia itself, mechanical ventilation, intraoperative events like tachycardia, hypertension, inordinate fluid therapy, overall surgical stress, and anything that affects the loading conditions, maybe preload or the afterload, can elevate this LA pressures and precipitate pulmonary edema in these patients with diastolic dysfunction. You have to be very, very cautious, and you have to know that there is a very, very narrow therapeutic margin for fluid supplementation in these patients. The fluid protocol should concentrate on reducing the LV pressures and have optimum preload. Perhaps the preload has to be adequate enough to avoid low cardiac output state as well. Okay, so overzealous fluid administration needs to be deterred to avoid postoperative heart failure and pulmonary edema, as it leads to persistent increase in the LV filling pressures, which eventuate pulmonary edema. So the judicious fluid administration policy, avoidance of stress response, invasive monitoring like CVP, PA, catheter, cardiac output monitoring, or TE, besides meticulous comprehensive anesthesia management. Regional anesthesia, as and when it is possible, may prove asset in these patients. These patients are totally intolerant to atrial fibrillation. Why? Because the atrial kick is lost in them. So it is very important that you preserve sinus rhythm in these patients. Tachycardia truncates the last phase of diastolic filling, and which is very important for LV end diastolic volume or the preload. So tachycardia is a big no-no. Brady is also a big no-no. So maintain the heart rate. That is the main crux. Hypertension, increased wall tension, again will worsen diastolic dysfunction. Ischemia, don't allow, it will increase the pulmonary venous pressures. So always maintain the cardiac grid in these patients. Ischemia is not allowed. Volume overload is bad because it may end up in pulmonary edema and increased LV EDP. And that was all about today's session of evaluation of diastolic dysfunction and in short, the anesthesia management of it. And do visit my website, cardiacanesthesia.in. There is a lot of theory present on the website, and it's going on for now 7 to 8 years, I think. And my book is also there. You Are a Star, very inspirational and motivational book. It is available on Amazon. Do read it. And thank you so much for having me today. Thank you.
Thank you. It was a wonderful talk. It is a difficult topic, no doubt about it. And one has to do it, study it, do it again, read again, remember your previous experiences.
And reread it basically.
And she has covered all the grades and even pulmonary vein, many aspects of diastolic dysfunction, and how the pseudonormal should be diagnosed very wisely before operation. And all these studies are done basically on transthoracic. Muralidhar, I wanted to ask, who is the audience right now? What is their, are they?
The audience is a mixture of cardiothoracic surgeons, cardiac anesthesiologists, critical care specialists.
And they're doing echo right now. They're doing echo right now.
Yeah.
They're doing echo right now. So it is a difficult topic, and we would discuss as the discussion goes on. And should we tackle the chat box questions first and go ahead?
Yeah,
or
as we wait
should I ask few questions before?
Yeah, you can do that. You can.
Amarja did mention about pseudo-normal diastolic dysfunction. So in that, if you can go to your slide, Amarja, that is pathological impact, showing all the grades of 1, 2, pseudonormal, and 3. If you can go, I think we would be able to discuss it in a better way.
Yes, ma'am.
Not this, just before that.
This?
Well, you can.
Not this, not this.
You can. No, go ahead. Yes. No, go down.
The blue one you
Slowly,
want.
slowly.
This you mean?
No,
No, not this.
I
The
want-
another one. Last one. Last one.
No. Go to previous slides. Go to previous.
Ma'am, this you mean?
No,
This?
no.
No.
It's okay. You can show this image. That is also fine.
This is also good one. Yeah.
I just wanted to explain a few things over here. Just concentrate on the, just show them, Amarja, this pseudo-normal. This, okay? You feel that it is just like the normal. Now you
Yes.
show them normal. So E more than A. So you think patient is absolutely fine.
Normal.
This is the situation where pre-operatively one must, if you have a chance to do transthoracic, and if you see this type of pattern, patient is hypertensive, patient is having some complaints of breathlessness after exertion, you do Valsalva, and then this pattern is converted to grade 1. Just show them grade 1. So this is how you reduce it, because this is at the cost of increased LAP that E has become more at the cost of increased LAP, that is pseudo-normal. This pattern looks like normal at the cost of raised LAP.
Pressure.
Yes. So you want to see whether it is normal or converted to grade 1, which Valsalva. So if you give Valsalva and reduces LAP by doing Valsalva, and if you get grade 1 type of pattern, that means grade 1.
Yes, this.
If you get this pattern, it's a very simple procedure, bedside procedure. Just ask him to hold his breath and breathe against the closed mouth and nose. You get this pattern, that means you are dealing with a grade 2 diastolic dysfunction pre-operatively. It is a warning signal, because during operation you may convert him to grade 3. So this is what is very important, and this is the crux of all this, that identify pseudo-normal diastolic dysfunction, because it looks like normal, but it is not. The moment you give more fluid, the moment you give more vasodilatation, they are going to go off the balance. That is one important point I wanted to impress upon everyone's mind, that see pre-operatively, if it is looking normal, and with Valsalva it is getting converted to grade 1, that means he is in grade 2, which we are likely to push him to grade 3 very easily during surgery. Okay, that's it. Then coming to L wave is simply means that there is tremendous rise in LA pressure. So there is continuously flow from LA to LV. And so you see that bump in diastasis, where you are not supposed to see any flow, any velocity, any flow, where you see that bump. That means patient is already having raised LAP. Whether patient is having raised LAP or not is the main thing we have to understand, because that is where your whole intraoperative scenario is going to change. Patient may deteriorate with your, management. That is very important thing. Another important thing is that U-shaped curve, that is in healthy normal patients, you do see grade 3 like pattern. Just show them grade 3 now. Correct. So in very healthy patient, young patient having good exercise and nice lifestyle, you do see this. You do see even pulmonary vein reversal, S less than D. Just show them that. These two can be seen in healthy young normal patient. So do we label them as diastolic dysfunction patient? No, you put tissue Doppler, and tissue Doppler will differentiate. When tissue Doppler comes normal, just show them tissue Doppler. When it becomes normal like this, that means he is a just young adult with vigorous LV contraction with these two patterns. This is known as U-shaped curve in diastology. Okay, this is very important. Athletes, young adults, they do show these abnormal patterns, we think that they are having diastolic dysfunction, but they are absolutely normal. Okay, let's go to chat box now. Just come off your presentation. Okay. Dr. Muralidhar, how do we address the questions?
See, the first question
Okay,
I can see
I
is
will just see.
Yes,
Yeah,
yes.
yeah.
grade 1, 2, and 3 diastolic
How to
dysfunction based on
differentiate?
E by E
So
and
we have
A
just
and
said
E
it.
by
We have just told it, I think, in detail. How do we differentiate grade 1, 2, and 3 diastolic based on E and A wave? That is what I was explaining all the time. And E prime and A prime. Okay. And how to perform Valsalva maneuver? Just now, madam has told that you have to ask the patient to breathe rigorously with closed mouth and nose.
No,
And
exhale, exhale. Try to
sorry,
exhale.
exhale. Exhale.
Just do Hanuman-like thing, Hanuman.
Yes.
You know,
Exhale.
blow
with-
your cheeks. That's it. Very simple.
And
Actually, for the first question, I would like to give one analogy.
yes, sir. Please.
How what is grade 1, grade 2, grade 3, grade 4? This is just an analogy to understand what is happening. Think that the left ventricle is the master. Think that left ventricle is the master and left atrium is the servant. This only analogy. Each chamber has its own importance, but just to understand what's happening, I would like to make you think that LV is the master, LA is the servant. Normally, most of the work is done by the master. The most responsible work is done by the master, and the servant does little bit and sees that everything is tidy in the house and everything is running properly. It does about 20% of the work, 80% of the work is done by the master. But what happens when the master is a bit sick? Suppose the master becomes sick, the servant has to take over a little bit. So the E wave becomes smaller. E is the master, A wave is the servant. So now there is a condition where the left ventricle is not well, which means master is not well. So the left atrium has to do little more work. So it becomes bigger. But after some time, what happens? Master condition becomes little worse. I mean, his whatever problem he's having becomes worse. So the left atrium continues to work and is trying to contribute something, and the master also trying to cope up. So the relationship is all re-established. That is pseudo-normal. And then what happens? As the disease progresses, left ventricle becomes worse, and the left atrium now says to the master, I have done enough for you. I will do only little bit, and it becomes smaller.
Beautiful.
So the E wave becomes larger and A wave becomes smaller. And this is just an analogy to say that what is happening in diastolic dysfunction as the disease worsens. Initially, the left atrium will compensate by contracting vigorously and keeping the stroke volume out good. But later on, left atrium also says that I'm sorry, I've done enough for you now, and you do whatever you want, and the master becomes E wave becomes bigger. But the only difference is that the deceleration time decreases. So this is just an analogy. Just uh, keep this in mind when you want to follow what's happening in this. Thank you.
Nice.
Please continue with the other
Thank you.
questions.
Nice, nice.
So that was a nice analogy. And we will take the next question. Next question is, how do you perform VP? Somebody has asked, how do you, can you explain how you exactly calculate VP? Okay, I will explain. What you have to do is you have to just take mid-esophageal 4-chamber view first, and you have to put the M mode scan in the center. And first you have to put the color. And after putting color, you have to put the M mode. And at this time, the Nyquist limit has to be 75% of the E wave velocity. Okay. And that time you see the M mode. In the M mode, you will see a colorful pattern, vertical pattern. At that time, the first 4 centimeters from the mitral valve to the apex was 4 centimeters. You have to just measure. That is how a propagation velocity is measured. Ma'am, can you explain
Yeah,
on
it
this?
simply, it is not taken as a first measure, because there are many things which makes it change. But still, the moment LV is not able to relax, see, there is a gush of blood from LA to LV during E wave, because the LV is relaxing and LAP is rising. So you try to measure that, and it has to be as straight as possible, which she has already explained. The moment it becomes slanting, the moment it becomes like this, start sleeping, that means patient's LV is not dilating well during relaxation. And that is why there is no reduction between LA and, it is all interplay of LA and LV pressure. There is no reduction of pressure between the two chamber. So blood slowly goes into LV. So it slants like this. So that is why it has to be straight like this. Though it is not considered as a primary measure to diagnose diastolic dysfunction, but yes, it is a good measure to diagnose it. And they do E by VP ratio to know the approximate left atrial pressure. We want to know LAP, that is the main thing. Is there any other question over there? How to
There are several questions.
Yes, people have asked, how do we do it, diastolic dysfunction diagnosed in atrial fibrillation patients? Because I have told many times that in AF, A wave might be absent, so that question might be there. In this, you have to take always not the single waveform, but you have to see it within 5 to 7 beats, and then you have to calculate. Secondly, more than E and A separately, a ratio of E by E prime is usually taken in case of AF patients. Okay, so whenever this tachycardia or EF, E by E prime more than 20 suggests high LV filling pressures.
No, during atrial fibrillation, there is no A wave at all.
Yes.
There is no question of E by A. That is outdated. So you have to do E by E prime. That's it.
E by E prime,
And
more
it
than
is
20.
a difficult scenario, but yes, it is the fact that he is having atrial fibrillation, it is due to altered LA physiology and pathology, dilatation of LA.
That's right. That's right.
So
There's no
that
A wave.
A,
So the EA does not come into picture here. There is no A wave. And the parameters which can be taken into account is the deceleration time. It's more or less than 160 milliseconds. And IVRT less than 65 milliseconds indicate the presence of restrictive filling pattern. And E by A ratio can be taken. And as Dr. Sanjeevani mentioned, E by VP more than 1.4 is indicative presence of diastolic dysfunction. And invariably, these patients have left atrial enlargement, and some amount of diastolic dysfunction is most likely in this patient.
Okay, there is one more very interesting question. I would like to address that as well. How to do a Valsalva maneuver in a ventilated patient? So this is very important. You should know, because in a normal breathing patient, we know how to do a Valsalva, but in ventilated patient, how to do a Valsalva? You have to switch on to manual ventilation first. If the patient is on volume control, they take the patient on manual first, and you have to adjust the pressure release valve at 40 mm of Hg. Okay, and then a inspiratory pressure of 40 mm of Hg again is given for minimum of 10 seconds, and that is how you have to give the Valsalva maneuver in this patient. So got it?
who has asked this question? Can I know that who is the, I mean, what is this? No, I mean, whether he is a heart surgeon or critical care. But during operation, and if you want to diagnose such situation, you have to be very careful while giving Valsalva, because it is a very, it reduces blood pressure drastically.
And cardiac output is drastically
Yes.
reduced in the during
in
this.
awake patient, it's a different scenario. During surgery, it's rather.
Yeah, the other alternatives for Valsalva maneuver on the patient who is on a ventilator is anti-Trendelenburg position.
Yes, yes. You
Yes.
can give
And
head up.
otherwise is you can give some nitroglycerin. And if the pattern reverses to impaired relaxation, it represents a pseudo-normal pattern. If the pattern from normal becomes impaired relaxation, it will be a pseudo-normal. And
That was good, I think, and we have answered many of the questions. And someone has asked, ma'am, is there any significance or new onset diastolic dysfunction in critically ill and septic patients? Is grading of diastolic applicable in critically ill septic patients? Yes, grading of diastolic dysfunction is applicable in critically ill septic patients as well. And new onset can occur if the patient has ischemia, infarction, or it cannot just happen if it has to occur acutely. There has to be some insult to the myocardium, okay? And otherwise, in long-standing patients who get critical, it can be present. Does using lusitropic shall be used to reverse the diastolic intraoperative? What is the role of diuretics in diastolic dysfunction? Diuretics, yes, someone has previously also asked about diuretics. And yes, diuretics can be used, yeah, but we have to be very particular. We have to maintain optimum preload as well. So it is not like you can compromise on the preload. So a very delicate balance between the preload and your whatever urine output you get out of your diuretics, delicate balance has to be maintained.
Muralidhar,
Sir,
I
or
would
madam?
like to comment on this. See,
yeah, sure,
it all
sure.
depends on what is the grade of diastolic dysfunction. If
Okay.
it is grade 1, there is less rise in LAP. Heart is just trying to manage and push blood from LA to LV by increasing LA pressure. There, one can have little support of fluid. Just see, give 100 ml, 50 ml and see. If it is improving, one can give because it is a stiff ventricle, LA is also dilated. But in grade 3, one should not give fluid. You have to be very careful. On the contrary, you may have due to mild diuresis. See, mild diuresis and mild dilatation of vessels, that is lusitropic drug, is very important because it is a precarious balance and there is a steep pressure volume curve of diastolic dysfunction as against flattish pressure volume in systolic dysfunction when you compare with your normal Frank-Starling curve. So being the steep curve, neither you can give severe diuresis nor you can give you can make him give more fluid. It is a very tight
It has to be
rope
cautious.
walk, and you have to judge it on the table.
Instead of saying
That is
mild, I will
very
say cautious.
Grade 3, you may need lusitropic drugs more or maybe diuretic, but in grade 1, sometimes you do need little fluid.
Right,
You're justified in giving that.
Correct. And I noticed that we have faculties from other places. Parimala, Minati, Jaswinder, Hetal. Would you like to comment anything, add anything here? Parimala? I saw Parimala in the group.
Muralidhar, I would like to...
Minati, Jaswinder, Hetal, anybody wants to say anything, please feel free. Unmute yourself and say. Yeah, tell me, Sanjeev.
And one more thing, I would like to explain this group little, in detail. If you can show Amarja your DCM video, dilated cardiomyopathy with that pacemaker lead, or even the previous one.
Yes, yes.
Let's discuss on that because it is important.
The difference between diastolic dysfunction, pure diastolic dysfunction, and dilated cardiomyopathy is that the walls of the LV are thin in dilated
You can show that
cardiomyopathy,
diastolic
whereas
dysfunction in DCM, that video with the pacemaker wire. Just show that. Share the slides.
This, na? Ma'am, this only, no?
No, we are not.
no,
able
we can't
to.
see. We can't see.
You can't
Not
see.
shared.
But this is very important concept.
This?
Yes, yes, yes.
Yes.
Now see here, see what this patient is having dilated cardiomyopathy is prima facie is a systolic failure heart. Okay.
Systolic dysfunction.
Either
Yes.
it is a ischemic or viral or whatever it is, or COVID or whatever. But prima facie, it is a systolic, severe systolic failure. His ejection must be 25, 30. Okay.
20.
And obviously this is CRRT lead. And this patient the concept over here I want to impress upon your mind is that systolic heart failure always have diastolic heart failure. But this is not the primary diastolic heart failure patient. This is systolic heart failure. That is also known as heart failure with reduced ejection fraction. And
Yes.
what she showed of that HOCM or any hypertensive patient or aortic stenosis, that is prima facie diastolic heart failure, which later on they may have some systolic heart failure later on. Usually it is sometimes both of them are present. Our aim is to know which is dominant before operation. Whether it is a systolic heart failure, because this patient needs different management, and thick heart with less volume. Diastolic heart failure has less LV volume in heart at normal scenario, provided because it's a thick heart, it cannot relax, it cannot dilate. The stroke volume is hardly 30 ml, 35 ml. In aortic stenosis, there is low flow, low gradient, and with normal ejection, with low ejection. So basically, their LV volume is very low in diastolic heart failure. And in systolic heart failure, you see this dilated heart. That is one important concept one should know before operation.
That's right. This
Okay,
is not a
Muralidhar?
pure diastolic dysfunction.
Yes, this is prima facie
Yes,
systolic heart
systolic
failure.
dysfunction.
Yeah.
Yes, ma'am. Thank you. Thank you so much. Ma'am, there is one question. Any changes in waveform due to MS or MR?
Nice.
So,
Question.
so if it is ischemic MR, it might be associated with systolic heart failure as well as associated diastolic heart failure, which madam has just told. And in case of MS, with MS, it is very rare that you get a diastolic dysfunction because the whole pathophysiology of MS is different. Case presentations or the age of presentation is different. So there are many, but yes, changes might be there. But these two scenarios of MS is very, very rare.
I would like to address this. See,
Yes.
MS is the only situation, only valve
Yes.
situation where LV is rather protected. Okay, LV is not neither dilated nor hypertrophied. Tissue changes occur very late.
Very late.
If you are ignoring that patient, but otherwise LV is very protected and nice LV.
Always
present.
underfilled and
MR,
small
AR, aortic
LVs
stenosis,
present.
all these patients, all these valve patients, they do exhibit diastolic dysfunction, but grading of it is very difficult and it's a different topic altogether. I mean, it's a nice question because only MS, you don't get diastolic dysfunction, LV is protected.
Yes. So I think we have addressed, Muralidhar sir, we have addressed all the questions, not left any.
Yeah, we have 2 minutes to go. Any comments from any of the participants?
Parimala, then
Yes,
Jaswin.
good morning. Good
Yes,
morning,
yes.
sir.
Good
and
morning, yes.
Yeah,
Good
Parimala.
morning, ma'am.
Nice discussion from Dr.
Good morning,
Amasya.
ma'am. Good
Thank
morning.
you, ma'am. Thank you so much.
Wonderful.
Yeah.
It was wonderful presentation as well as wonderful discussion, sir.
Thank you, ma'am. Thank you. Thank you.
One comment is
Yes,
in
please, yes.
elderly patients who are not diabetic, hypertensive, or ischemic heart disease, still some of them post-operatively suddenly develop diastolic heart failure. It may be related to the fluid mismanagement and surgical stress leading to the antidiuretic effect. So these patients may benefit with mild diuretic, and we have to be on watch for diastolic heart failure and treat accordingly. So no, not a known heart disease patient, still they go into diastolic heart failure post-surgery. We have seen these patients and we have to treat urgently and improve their conditions.
Mhm.
Thank you.
One more important, Muralidhar, one more important thing which we have forgotten over here is history of snoring preoperatively.
Okay.
They do have severe diastolic dysfunction, but they don't have hypertrophy of the heart. They don't have blood pressure sometimes, but some changes occur in them. That do ask his wife rather whether the patient is snoring or not, and do diastology this thing. And what Parimala has said, many times there is no hypertrophy. Many times there is no hypertrophy, but still they do exhibit all these, especially diabetic patients, because it is a microvascular disease. Diastolic dysfunction is a microvascular disease. His angio may come normal, but still have ischemic pain. And these patients, they do exhibit this diastolic dysfunction, especially diabetics. So one should always do thorough evaluation before surgery.
The
And
other point I would like to,
diabetics don't have even chest pain also, you know. They will just,
yes. The other point I would like to mention is that even though the EF may be normal,
yes.
some of these patients will exhibit systolic dysfunction when you check the global longitudinal strain or spectral tract imaging. So in early stages, you can always see some associated systolic dysfunction, which is not evident by the usual techniques of ejection fraction and measurement of systolic function using fractional area, etc.
Another important point which we have forgotten, all of us, is LS strain, which
LS
is
strain,
incoming
Yes.
way, and one has, because grading is very complicated according to 2016 ASA guidelines. So normal LS strain, you are happy. Only one parameter, LS strain normal. You are happy to induce that patient. LS strain abnormal, you should be aware of all those things.
Yeah, LA has three functions. One is the reservoir function, conduit function, and the pump function. Just remember RCP. It's not retrograde cardioplegia. It is reservoir, conduit, and pump function. And the strain can be calculated for each of these functions.
And one more thing, I have just come across one patient. I read it that in severe LV failure, severe diastolic dysfunction, severe systolic function, raised LAP, raised LAP, everything. Patient was in sinus rhythm, but there was no A wave. So I just referred back to medical literature, and they do have this. This is known as atrial failure.
Okay.
So even though patient is in sinus, you do see only E wave and A wave is absent. Treat him, A wave appears. So it is a
That
beautiful
means the
scenario.
servant
I
is not
enjoyed that
working at
patient.
all. That means that the servant is not working at all.
Servant failed. He went to sleep.
I think we have crossed the time limit. Thank you so much for joining us. It was excellent talk and followed by deliberations from Sanjeevan and others who participated. Thank you so much. And before we conclude, I would like to inform you that on the 10th, we are having a cardiac anesthesia CME at Narayana Health, Bangalore, followed by 1 day of critical care echocardiography workshop on the 11th. If you are free, please join us. And the instruction to the candidate who are taking the exam is already mentioned. Based on that, please comply with the requirements. And till we see you next week, all the best and thank you so much. Thank you, Amarja. Thank you, Sanjeevani. Thank you, Parimala, and others who have participated. Thank you so much.
Thank you, sir. Thank you, madam. Thank you, everyone.
Thank you, ma'am. Thank you, sir.
Thank you.
Thank you so much, everyone. So with all your permission, I would like to conclude the session over here and looking forward to host you again. Thank you.